number 4. On number 4 of the November 2021 question. So Dr. Yaya, you can actually have the floor. Thereafter, questions and contributions we need. Thank you.
Okay, thank you, ma'am. I'm taking question number 4 as highlighted. Before going over, I just have to have some few apologies. Yesterday, my system has to stop, and I have to use the night. I have to take it for repair and use the night too. So I will have wished to have more slides and other things that will help. But however, I try to bring out some salient things. So the question said, a 35-year-old banker presents with left ankle swelling, pain and swelling, fever and malaise. These are the only information given from the question. So the first question said, mention 3 differentials. And another information was given. Patient reported having 3 recurrent episodes in the past, affecting the head of the first metatarsal of the big toe. So subsequent questions that follows were, what is your diagnosis after giving out this information? Then what are the 3 stages of the disease? Then according to academic American College of Rheumatology criteria, mention clinical, radiological, and biochemical features to make diagnosis. Then number 5 said mention 4 investigations. And number 6 said 4 classes of drug used in the treatment. Okay, having given the only information that he's a 35-year-old coming down with that pain in the ankle, left ankle and swelling, fever and malaise. So there are many things that could come here, and the arrangement may not necessarily be the way I arrange it. However, I think the top 3 should be top 3 among, but it could be anyone among them, depending on how someone reasons. So I think of rheumatoid arthritis should be one of the things should come out because the age is one of the commonest age affected, even though the gender was not given from the question. So it affects both smaller and larger joints, but usually they are symmetrical, and they can come with swelling, pain, they can come with fever, like our index patient. Gouty arthritis, yes, is common. The age may not be too good for gouty, usually 40, 50 and above. However, it can still occur, especially in a setting where there are background risk factor for that. So also they can present with this kind of pain and swelling, and also constitutional symptoms like fever and malaise. So again, septic arthritis is also a very good differential, thinking that the patient can have fever and occur at all ages. So, and they can occur at any joint, and they affect more of the larger joints to some extent. However, there could be background risk factor for septic arthritis. And again, the pain is usually severe and is a form of rheumatological emergency because even if it's not properly taken care of, there are associated high consequences of morbidity and mortality. So pseudo gout also is considered here, being the part of the body affected is usually lower limb, which is more for pseudo gout, and a large joint. However, knee joint is more commonly affected in pseudo gout. And one of the negative for pseudo gout is usually affects females more than males. Cellulitis is also very important. It could just be that it's inflammation of the, it does not involve the joint, it's just the skin. So cellulitis, and is one of the commonest differentials of acute gouty arthritis. And at a time, some patients were managed for gouty arthritis, and at last they may end up having cellulitis, especially in peripheral setting where they were not thoroughly evaluated. So it's a very good differentials. Then also consider reactive arthritis, looking at the age of the patient is a sexually active age. And again, there could be some other things, 2 weeks or 1 week precipitating the joint pains. And again, reactive arthritis affect joints of the lower limb more than the upper limb, and they could come with fever, swelling, and pain. So those are the things I consider. However, aside, there are a variety of monoarticular arthropathies that could present with that. But I agree with the ones I placed in the group. There could be many even. So going for that, the question give out an information that this thing has been recurrent, and in the recurrent episode, patient had been having 3 recurrent episodes and affecting the head of the first metatarsal of the big joint. This has simplified a lot of differentials that the only thing that should be considered here is gouty arthritis versus rheumatoid arthritis. In gouty arthritis, they could affect all other joints. However, the first metatarsophalangeal joint is the most commonly affected. Also, metacarpophalangeal joint of the first two finger will also be affected, but the commonest joint is first metatarsophalangeal joint of the big toe. Unlike in rheumatoid arthritis, yes, rheumatoid arthritis is the number 3 joint affected. Metacarpophalangeal of the fingers, especially the first digit, is more commonly affected. They are more commonly affected compared to metatarsophalangeal joint of the big toe. However, as I said, for all of them, they could affect this joint as one of the commonest presentations. So in that, I considered gouty arthritis here with this information more than the rheumatoid arthritis. However, there are no much slight difference for that. So what are the 3 stages of the disease? In some of the literature I consulted, so many have their own 3 or 4 stages of this disease. But I agree with this asymptomatic hyperuricemia, which is usually the initial stage. Then sometimes they can have acute gouty arthritis, they will have the flare of the disease. Then for some reason or the other, they can stay silent for a very long time, intercratal gout. And sometimes they can have some whitish deposit in the skin, joints, and other parts of the body. In that case, especially in patients that have a sustained elevated level of uric acid, so they can present with chronic tophaceous gout. So these are some of the stages. As I said, in some texts, the way they arrange their own, one of the texts said acute sodium urate synovitis, which is acute gout, chronic polyarticular gout, meaning it could become chronic, affect some other joints in the body, then chronic tophaceous joint, and urate stone formation. So those are the various stages being identified for this disease. So number 4 said, according to American ACR criteria, according to ACR criteria, I mentioned clinical, radiological, or biological features to make the diagnosis. So there is a criteria for diagnosis of acute gouty arthritis, especially the one done by American College of Rheumatology. One of the earliest criteria was made in 1977, but subsequently and more recently, 2015, the criteria was revised. And so far, that was the only one I have laid my hand. I don't know whether there is a new criteria, but I asked one of the rheumatologists, he was not sure, but he said he's also aware of this 2015 as the latest. So if you could see from the criteria, there are clinical features, there are laboratory features, and there are radiological features. I have another criteria that is more explain more than this. However, I could not be able to point it. Maybe later I'll update it in this slide. So for the clinical criteria, you can see there are 4 things to consider: pattern of joint. And before this criteria, there is a guide that's, okay, one, there is an entry, then there is sufficient. If you have at least 1 episode of swelling, pain, and tenderness in a peripheral joint or bursa, just like our index patient, you need a sufficient criteria to fully diagnose gouty arthritis. What is that sufficient criteria? Is if you can detect presence of monosodium urate crystals in symptomatic joint or bursa, that's enough to diagnose a patient with gouty arthritis. However, if you cannot do that, you only have 1 episode of swelling, that means you have entry criteria. You need to have other criteria. You need to have 6 or more of the following clinical, radiological, to make a tentative diagnosis of gouty arthritis. Okay, let's go back to this, because this one I could not, it's only the clinical. I could not be able to bring out the radiological, and which I can do because it's more explainable. But we can use this one for now. So you can see pattern of joint or bursa involvement. They are graded. If it is ankle, metatarsophalangeal, mono, or you see metatarsophalangeal joint of the big toe is given a more consideration. Looking at the score is 2, unlike the ankle. That's to tell us that that joint is very useful in diagnosis. Then characteristic episodes ever. So the characteristic episode could be 1 characteristic, 2 characteristic, 3, and those characteristics, they are well highlighted in the other one that I could not get the other maybe subsequently. So time course of episode ever, again, if it is 1 episode is 1, recurrent, because we said even our patient has a recurrent history, 3 previous history. So that recurrence is also very important for the diagnosis. is having a mark. If you have a total score of 8 after, you could say somebody have tentative diagnosis of gouty arthritis. Then for the labs, you use serum urate, you use synovial fluid. Serum urate of varying degree, because usually during acute attack could be normal, could be high, but the only thing, it could be below a certain range that uric acid is known to precipitate and get deposited. But these are the values and these are the marks. Imaging, there are not pathognomonic imaging features, but there are some highly suggestive of features on imaging, both X-ray and ultrasound. They're highly suggestive of gouty arthritis. And if they are present, they are given a high consideration of 4 marks. So I'm going to mention that maybe subsequently in the. So these are the just brief of American College of Rheumatology criteria for diagnosis of gout, including the clinical, laboratory, and imaging. So going out for the remaining part of the question, said, what are the 4 investigations we like to do? Joint fluid microscopy is very, very important. It's one of the most important tests that we should do, and is almost specific for gouty arthritis, in which we expect to see needle shaped negatively birefringent crystals, unlike that, just to differentiate from other form of crystal arthropathy, commonly pseudo-gout. Then uric acid. As we said, uric acid may not be too important in making the diagnosis. However, you may need to know the baseline because it may help subsequently in the management. And we have to believe that it could be normal in most cases. It could be high also in most cases. And again, it shouldn't be lower than a certain range. Uric acid, electrolyte and creatinine, checking for kidney function is very important in 3 ways. One, in that one of the commonest cause of hyperuricemia leading to gout is impaired excretion of the uric acid by the kidney. So we need to see the background. Could it be that it's because of the renal disease, which one of the cause that this gout is occurring, or is it big? Because we want to, most of the drugs that we are going to give, we have to be cautious of the kidney function. So that's also very important for that. And again, could it be that it's a complicated form of gout? Because acute gout, if not treated, persist, can lead to formation of stones, urate stones that could deposit in the kidney and subsequently causing impaired function of the kidney. So these are the 3 reasons why we should go for electrolyte and creatinine, which is very important. Joint imaging are very important, especially if you could not make diagnosis from the clinical and laboratory investigation. You may need to do X-ray, which I said there are some features that are highly indicative. There could be X-ray features, there could be ultrasound features, which we should see subsequently. Then other investigation, just like any other disease, we need to do full blood count. We know the importance of that. We need to do other things to prepare our patient generally, and if possible, to rule out some other common differentials. So then 4 classes of drugs used in the treatment. There are wide varieties of drugs used for the treatment of gouty arthritis. NSAIDs, naproxen, diclofenac, indomethacin, and others. Colchicine is also used. Glucocorticoids. These are used for acute attack. Prednisolone, methylpred, triamcinolone could also be used at some point in the joint. So xanthine oxidase inhibitors, commonly allopurinol and fepuzostat, they could also be used. Monoclonal antibodies, anakinra, interleukin-1, and canakinumab, that interleukin-1b, they could also use. Then uricosuric agent, probenecid, sulfampyrazone, and benzbromoid, even though they did not get widely accepted use, but again, they're also part and parcel of some of the treatment of this disease. Then for some reason, we can use recombinant urate oxidase, pegloticase, and rasburicase. Rasburicase used to be drug of choice for the treatment of hyperuricemia of thrombolysis syndrome. So these are the questions. Let's briefly, maybe 5, 6, 7 slides, just to highlight some of the key things that we have not mentioned. We can see the joint is commonly affected, metatarsophalangeal joint of the big toe. You can see there are swelling and masses of uric acid tophi there. And these are tophi. They can be deposited. We said these are, apart from the metatarsophalangeal joint, they can also be deposited in metacarpophalangeal joint, especially of the big toe, as you can see here, and there are other places there. You can see it as big as this. And we also have to note that this is an erosive form of arthritis, because it's better to classify some of the arthritis as erosive and non-erosive. So gouty arthritis is a metabolic disease caused by monosodium urate monohydrate crystals deposition, and they usually affect Recently, high uric acid was considered to be one of the components of metabolic syndrome. So presence of that high hyperuricemia, it warrants looking for other components of metabolic syndrome. It affects males more than the females. Usually females is seen after they attain menopause and commonly affect middle-aged to elderly men and postmenopausal women. It's caused by impaired excretion of uric acid. This is in more than 90% of cases, or in any condition that lead to increased uric acid production. As we can see, first metatarsophalangeal joint is commonly affected, just like our index patient. The clinical features, they can present with sudden onset of agonizing pain, swelling, and redness of the first metatarsophalangeal joint, just like our index patient. And the attack may be precipitated by alcohol, dehydration, or by starting a diuretics, trauma, surgery, and other form of stressful activities, even some food. Other joints affected are ankle, wrist, finger joints, and knee joints. Just like our index patient, again, he has recent attack came with ankle joint swelling. Fever and other constitutional symptoms may present just like our index patient. Tophi may be seen in the skin and around the joints, fingers, ears, or Achilles tendon, as some of the images are highlighted. So these are briefly the causes of hyperuricemia. They are not exhaustive. There are a lot of them. But again, as we said, under excretion of uric acid is the commonest, more than 90%. So there are some genetic aspect of that. Chronic kidney disease is top. That's why we need to check UACR ab initio. Insulin resistance is also shown to promote that. Hypertension, just alone being hypertensive, is a risk factor. Thiazide and loop diuretic that have one of their side effects of hyperuricemia. Low dose aspirin is also shown to do that. Cyclosporine and pyrazinamide. Pyrazinamide for the treatment of TB is also known to do that. So these are some of the overproduction. Usually diet alcohol, high cells on other conditions like myeloproliferative disorders, lymphomas, even psoriasis. Psoriasis is becoming one of the also diseases that be considered as having a wide association with many other things, cardiovascular, uric acid, and other metabolic disease. So identify genetic factors. There are some enzyme deficiencies that are known to predispose to that. Two of them are due to the deficiency of those enzymes, and one is due to overproduction of that enzyme. One of the common one is hypoxanthine guanine phosphoryl transferase, which is seen in Lesch-Nyhan syndrome. And again, another one is glucose phosphatase deficiency that is known to cause bronchial disease. It's also its underactivity is also that. But overactivity of an enzyme called phosphoribosylpyrophosphate synthase also is known to do that. So tumor lysis syndrome in chemotherapy is also one of the causes. As I said, there are other things like leg toxicity, hypothyroidism, and the list is not exhaustive, just to have an idea. So how do we diagnose? We said diagnosis could be clinical, as we see from the ACR criteria. You may need some lab support, you may need some imaging support. The lab support, usually you need to check for the uric acid. In most cases, it's more than 6,600 micromole per liter. And if you check it's not high at that time, you can recheck several weeks because it's known to fall immediately after an acute attack. And again, we should bear in mind it could still be normal. But again, there are certain range that it shouldn't be lower than that, like 360 micromoles per liter. So this is the synovial fluid analysis. We can see, I wanted to compare between the commonest differential of gouty, pseudo gout, but I couldn't do that. Time did not permit me. So you can see this is a crystal, it's needle shaped. This is what we expect, and it's yellow in color, and it's negatively birefringent. Okay, unlike the pseudo gout, which is one of the commonest differential, usually it's rhomboidal and it's positively birefringent. So the diagnosis, again, as we said, sometimes you may have a patient that does not fulfill the criteria for those entry criteria and supportive criteria. So you may need to do some joint imaging, or as just initial part of evaluation to know the extent of the disease. So there are some features that are known to increase the suspicion of gouty arthritis. One of them is erosions with overhanging edges. If you see the edges of that, as we said, is an erosive disease. So we expect to see an erosion, just like RA and some other forms. However, unlike difference with RA and other forms, the joint spaces are maintained. They don't have loss of joint spaces. And again, there is no periarticular osteopenia commonly, unlike the OAs and other aggressive erosive joint disease that comes with that. Then the borders look sclerotic, what they call cookie cutter or punch out. And the presentation usually is asymmetric among the joint with strong predilection to distal joint, especially in the lower extremities. So distal joint are more affected. Even though if you have the one that affects several other joints, we find that lower limb joints, lower extremity joints are more affected, and in an asymmetric distribution. So for the ultrasound, again, there is what they call double contour sign, which is hyperechoic irregular line of monosodium urate crystals on the surface.
Mr. Mohammed, you should be rounding off. You should be rounding off. Thank you.
Okay, so let's go for the treatment. For the treatment, the aim of the treatment is to reduce the pain because they come with acute pain. You also need to reduce the level of uric acid. You also need to prevent further attack. So you can see those that are used for the acute attack. The time may not is not enough, so we can see the list of the drug. NSAIDs, colchicine, steroids, topical combination therapy, interleukin-1 inhibitors. For the long term, we can go for allopurinol or febuxostat, but we have to make sure somebody's renal function is good. Febuxostat is preferred in patients with some impaired renal function. Again, allopurinol, even in patient with renal function, good renal function, we have to look for other side effect of that. We have to counsel the patient about abdominal symptoms like diarrhea and skin rise. Skin rise could be simple, could be toxic. They could also come with drug reactions. So these are the things we should consider. And we should also consider more comorbidities as highlighted above. And for patients that have hypertension and uric acid, it has shown that losartan will favor them because it's both antihypertensive and it's also known to have some uric acid lowering properties. So I think this is just to highlight the pathway and where some of these drug acts. Allopurinol acts in zeaxanthin inhibitor. Then rasburicase is uricase, synthetic form. So what are those complications that we expect from this? Secondary osteoarthritis, urethral nephropathy, and for some reason or the other, they are known to have increased risk of infection. They could also lead to fractures because it's an erosive, they can destroy a joint. So fracture is also common in them. So sorry, I could not even write the references, but my references are Harrison, Kumar, and Clark, and one textbook from rheumatology and Medscape. Thank you very much. Comment, clarification, and other things are entertained. Thank you. Please pardon me. I have to use the night to prepare the slide because my system has stopped yesterday. Thank you.
Okay, so thank you so much, Dr. Yahaya Mohammed, and that was a brilliant presentation. So the floor will be open to questions, to contributions. If you have any question or contribution, you can actually put up your electronic hand, or you can send something to the chat room so we can read it out. Okay, so before anyone would ask a question, I just have one, a little maybe question or contribution. Okay, can you please go back to your question, please? Thank you. Okay, okay, just maybe a contribution. I don't know, like for the differentials, I don't know if osteoarthritis can be part of it as one of your differentials, though I know it doesn't really affect the metatarsal joint so often, but I don't know, since it's a monoarthropathy, I don't know if osteoarthritis can be there. What do you think, Dr. Mohammed?
Yes, Chief. As I said, these are just an eyes of the think back. Yes, there is common, even though the age may not be. But if he has background primary joint disease at this age, he could have also osteoarthritis. Even though, as you said, the joint affected is not the commonest joint affected, but it's also possible. It's possible.
Yeah.
Thank you. It's very possible.
Yeah, especially in the elderly, like in degenerative conditions, you can actually find the metatarsal joints being affected in degenerative conditions. Okay, thank you so much.
No problem.
Okay, does anybody have a contribution question for Dr. Mohammed? Okay, so I'm not seeing anybody's hand and I'm not seeing any message. Okay, there's something in the chat room. Okay, Dr. Ozo is saying, I thought osteoarthritis spares the ankle joints. Dr.
There
Ozo
is that
said,
saying. Okay, continue.
No. If you have anything to say to that, you can actually say.
I used to hear rheumatologists saying that, but does not mean that's why we did not bring it up. We just think it's a possibility. We are cautious of saying it's a differential actually. So any joint can be affected in OA, but there are joints that are commonly spared, but does not mean that they will never be affected.
Okay, thank you. So I'm not seeing any other electronic hand or contributions in the chat room.
We
So
aim to have 3 presentations today. I don't know.
okay, maybe we can call our chiefs if they have any contribution or questions as regards your presentation. Chief Christabel, any contributions or questions for Dr. Yaha here?
Dr. Ada, good morning.
Good morning, sir. You can go on, sir.
Good morning. Please, let me just say something briefly. Though it may not really matter, but Dr. Yaya, thank you for the beautiful presentations. From my end, I'm just thinking the arrangement of your differential. Yes, I agree with you. The first one, gouty arthritis, because of the metatarsal, the monoarticular, the tophaceal gout that was classically described here. And I was also thinking that after this gouty arthritis, the next in the differential should be that number 4, pseudo gout. They usually go hand in hand. And that is why in the differential, in the investigation which you mentioned, the how to differentiate them with the fluid, synovial fluid, microscopy, rhomboid, and the needle and the likes. So when we mention gouty arthritis, I think the next thing to come in is pseudo gout. The presentations are usually similar, and we have to look inward to differentiate them. And other thing we have in the questions also are in line. Then after that, the next thing, because of that fever, I think septic arthritis should also come high up. That is number 3. Before we now talk of other differentials, the septic arthritis, because of that fever should not just be jettisons. And when we are making our differential, we should look inward into the questions. The other, I agree with you. Even osteoarthritis should come down the line. It's a good differential. Yes, just like what some people said, ankle is usually spear, but this is a differential. So it should come down. The ankle, the wrist, which other one? There's this pneumonia we used to use then, sewa, which are the part of the joint that actually spared in osteoarthritis. But you know, in medicine, we usually say never say never. But deep shooting osteoarthritis, if it's coming up, should not come high up. It should be down. Thank you for the beautiful presentations.
Thank you, sir. Comments noted.
Thank you so much, sir, for your contribution. Well appreciated. Okay, so in the chat room, Dr. Ojo is saying that in osteoarthritis, the joints that are spared are the elbow, the wrist, and the ankle. And then it has the mnemonic called EWA, what our chief just previously mentioned. So the mnemonic is EWA, the elbow joint, the wrist joint, and the ankle joint. So these are the joints that are actually spared in osteoarthritis. Then Dr. Momodu is saying thank you, Chief Kayode, for your contribution.
Please, let's look in what I'm trying to remember. There's another S, Sewa. I can't remember now, but please let's think of that. Ewa, yes, sir. But there's another X. I remember one of the MCQ where they included RS.
Okay, sir. Thank you.
Okay, sir. Noted. Okay, noted with thanks, sir. Well appreciated.
Shoulder.
Okay, the shoulder. Okay, thank you. Okay, so somebody has just said the shoulder. So the mnemonic is SEWA. S for shoulder, E for elbow, W for wrist, and A for ankle. So SEWA is the mnemonic for the joint spared in osteoarthritis. Thank you so much. Then Dr. Ekele Roberts is saying, thank you so much for your beautiful presentation, Dr. Yaya. So thank you so much. I don't know if we have contributions from our chiefs or questions. Thank you.
Thank you, Chief.
Hello. Thank you, Dr. Yahaya. It was quite a beautiful presentation. Thank you so much. I think from all the contribution and all, I think there's really nothing to add. Should not he answered the question. I just wish he kept to time. It's still a little too slow for my liking. So you have to work on your speed. So besides that, it was a beautiful presentation. And please, just as Dr. Kayode mentioned, please rearrange your differentials because
Yes.
there's a way these things flow. So that you
Yes.
just be going for exam, they ask you similar questions, just be getting the marks. No time to waste. So thank you so much for a wonderful presentation. Dr.
Thank you.
What's this lady's name? Dr. Florence, yes, don't mind me. Thank you so
Yes.
much. I appreciate it. I think I was having challenges pronouncing the Kalamama. That was the one. That's the one that is my Thank you so much. Thank you so much. I appreciate thank you for anchoring. I appreciate your able bother asking for long. You just volunteered. Really love that. Love your positive attitude. Keep it up. So
Thank you,
Dr. I think the next presenter is 7:32. The second presenter should please share his slide. Dr. Yahaya, thank you so much. All those that contributed, thank you. Dr. Kayode, Dr. Ozo, Dr. Ekele, everyone that asked 1 or 2 questions, thank you. Dr. Akewumi, Dr. Momodu, thank you. So, second presenter, please share your slides. We don't have so much time. Let's cover as much as we can. We're trying to end this session soon.
All right. Thank you, Chief.
Thank you, Dr. Florence. Okay, who is speaking?
No, it's Dr. Enajo. Good morning, Chief. Dr.
Good
Precious
morning.
Enajo, good morning.
Good morning.
Good morning, colleagues, senior colleagues, teachers, and I'll be here to make a short presentation on snake bites from the 2021 question, and I'll be taking question 1. All right. So the question goes as follows. A picture of a farmer with a snake bite of the foot who has leg swelling, regional lymph node enlargement, tachycardia, BP 100/70 millimeter mercury, and respiratory rate of 25 cycles per minute. Electrolytes result shows mildly deranged urea and creatinine. Then the questions go as follows. What is the diagnosis? Name 10 signs and symptoms of envenomation. Name 4 species of snakes that can cause this problem. What are the signs of envenomation in this patient? Outline a treatment plan or modalities and mention the antivenom you will use. All right. So for the first question, what is the diagnosis? Snake bite with envenomation. That's what the patient has. Then name 10 signs and symptoms of envenomation. So we have some symptoms here and some signs. So some symptoms, especially in this index patient, leg swelling with discoloration, increasing pain in the bite side, nausea, diarrhea, vomiting, diaphoresis, difficulty in breathing, paresthesia, fever, excessive salivation, difficulty in swallowing. Those are the symptoms. Then signs, enlarged regional lymph nodes like in the index patient, edema and erythema at the bite site and in adjacent tissues, greater than 1 fang mark and scratches, necrosis, bullae, tachycardia, hypotension, spontaneous bleeding, and confusion. So the third question was name 4 species of snakes that can cause this problem. So name 4 species of snakes. So I'm going to start with the 4 species before I now enter the families of venomous snakes. So we have Echinus ocellatus, which is known as the West African saw-scaled viper, which is the most common venomous snake here in Nigeria. We have the Bitus areatans, Bitus gambonia. Then we have the Corsicus baculatus. Then we have the families of venomous snakes, which is your Viperidae, which are made up of vipers, and your others, which are cytotoxic hematotoxic, which the short form for it can be V is equals to AV. Then you have your Elapidae, which are made up of the mambas and the cobras, which you can see E is equals to MC, which is like the Albert Einstein equation. Then you have the Colubridae, which is your vines, twig snakes, bed snakes, boom slangs, which C is equals to BB, which if you're a cardiologist, you can say beta blockers. Then your Anthracipidae, which is your stiletto snakes, boring snakes, which is A is equals to BS. Then your Hydroperidae, which is your sea snakes. So what are the signs of envenomation in these patients? So in the index patients, you had leg swelling, regional lymph node enlargement, tachycardia, tachypnea, and deranged renal function. Those are all the things that were the signs of envenomation in these patients, which is going to help us in the management also of the patient. So the next question is, outline 8 treatment plan or modalities for this patient. So I'd like to start with the first one, which is your multidisciplinary team, which you already have in your access, which will have access to your accidents and emergency, which is your emergency care physician, your IDU physician, your hematologist, which I'll mention what all their roles would be, anesthesiologists, your surgeons, which include your bones and plastics and orthopedics, doctors, your cardiologists, and other professionals as needed. Then you have the implementation of your ABC of resuscitation. So you want to make sure that the airway is open. You want to make sure that you are also monitoring that airway. So in case the patient needs intubation and mechanical ventilation, which this can be done underneath the assistance of your anesthesiologist, which can be done by you, but underneath the assistance of an anesthesiologist. You must make sure that monitor your vital signs and establish that the patient has most likely two lines, but one should be a large bore IV access with which you would like to initiate your crystalloid infusion for. Then you have to restrict activity for this patient. So the limb that has this bite needs to be immobilized according to WHO guideline for management of snake bites. Make sure it's immobilized. Even went as far as saying that you need to put the leg into like a casket, band it down, not hold it down, but it should be in something so that the leg cannot move, so it doesn't worsen movement of the venom, the envenomation becoming systemic. Then you have to get a focused history. What do you want from this history? You want the description of the snake, because that will help you also to know your antivenom that you're going to use. The timing of the event, when did it happen? Did it happen yesterday? Did it happen 2 hours before a patient presented to the accident and emergency? So it can help you in the evaluation of the patient. You like to take then onset of symptoms. When did the first symptoms start? There's systemic symptoms, which could be nausea, vomiting, syncope, which could be from an arrhythmia, bleeding. So some of the things that help you point to systemic envenomation also are going to be very important. History of allergies also, which is going to help you also when you're giving medication to the patient, and comorbidities, which could be cardiac, respiratory, or any other systemic comorbidities. Then for the investigations and laboratory tests, you want to do the classical one, which is going to be your 20 minutes whole blood clotting time, which is going to be done in a glass tube in the accident and emergency. Then you want to do your full blood count, which is going to show if the patient also has infection or elevated WBC counts or thrombocytopenia, which the patient might have DIC also. So you might see thrombocytopenia in those patients. Then you want to do a serial EU creatinine, which in the index patient, the patient already had elevated and deranged electrolytes, or which needs to be a serial monitoring of the electrolytes because things change with these patients. You want to do a clotting profile, which is your PT, APTTK, INR, APTT, and PTTK, INR. You want to do a urinalysis because you want to evaluate for hematuria and rhabdomyolysis in those patients. You also want to do a grouping and cross-matching for whole blood, preferably, or if you don't have whole blood, you want to go for packed cells and other products, which include your FFP and platelet concentrates. You also want to do a creatinine kinase for this patient, which is markedly elevated in snake bites and D-dimer. Then for envenomation first, for the index patient, what are the indications in this patient that this patient would need envenomation, anti-venom in this patient administration? So there's a small table by the side that shows signs and indications for anti-venom administration in African snakes. So this patient had local, based on this chart, that's after I finished doing my 20-minute WBC, patient might fall into systemic envenomation, but based on the history alone, the patient has one of the local signs for anti-venom administration. The systemic envenomation signs include neurotoxicity, spontaneous systemic bleeding, cardiovascular abnormalities, hypotension, shock, arrhythmia, abnormal ECG findings. Therefore, your local signs of envenomation could include extensive swelling, rapidly progressive swelling, bites of fingers and toes, and because they are end arteries. So that is a sign for anti-venom administration. So how do we give this anti-venom? So the dosage would depend on the severity of the envenomation in this patient, which if it is mild, you want to give about 5 vials, which is 50 mils. You want to put it in normal saline to give at a dose of 5 mils per minute for 1 to 2 hours. If it's moderate cases, you're going to give 5 to 10 vials. Severe cases, you're going to give 10 to 20 vials with a maximum of 25 vials. You're going to repeat this after 1 to 2 hours. If there's bleeding and neurological symptoms which are persistent after this first dose of anti-venom administration, or you want to give after 6 hours if the 20-minute whole blood clotting time is still coagulable at that time. So you want to pre-medicate some sets of patients. You want to pre-medicate patients with atopy or previous history or previous reactions to products of equine sources, because we know that the anti-venom is made from equine sources, and your pre-medication is going to be from your adrenaline, hydrocort, or antihistamine. So you also want to treat pain. One of the modalities is going to be pain management. In these patients, you can give oral analgesia or IV opioids, which are preferred. You want to stay away from aspirin or NSAIDs, which could worsen venom-induced coagulopathies. Wound care also is a very important modality of management in which you want to have limb stabilization, especially in the index patients. And eventually, if there's necrosis of the area, you want to do wound debridement. That's after you have given your anti-venom. Then you also want to prevent tetanus. If the patient has completed primary immunization, you can give a booster dose, which has been given in the last 10 years. You can give a booster dose of tetanus toxoid. Then you want to also check for complete identification and management of complications. So for anaphylaxis, you could have early and you could have late, which is your serum sickness. Early could be your type 1 and late could be your type 3 hypersensitivity reaction. So for the type 1, you want to stop your antivenom first. Then you want to give your adrenaline, which is preferably IM. That's 0.5 milligrams of 1 in 1,000 adrenaline. You want to give it over 8 minutes. You want to also give hydrocort 200 milligrams IV hydrocortisone. You also want to give an antihistamine plus 1 milligram per kg phenylhydralamine. You want to give that also. Then you want to keep on rechecking the vitals every 10 minutes. But it's important to note that you will not stop despite this reaction, you will just stop, treat for the reaction, but you will still give your antivenom at a diluted dose. Then you repeat the adrenaline. You can repeat the adrenaline up to about 3 times. Then if the patient now enters shock from the anaphylaxis or shock even from the snake bite, you can administer dopamine IV 2.5 to 5 milligrams per kg, 5 micrograms per kg per minute. Then the second type of reaction could be a serum sickness, which can happen at least 2 to 6 days after your snake bites, which you can now give the patient prednisolone for, and which will taper down for 1 to 2 weeks. Other complications, like in this patient can have worsening renal function, in which the patient might eventually need hemodialysis. There could be compartment syndrome in this patient, in which he will need physiotomy in this patient to reduce the compartment syndrome. You could have local wound infection and necrosis, which can even lead to amputation. A patient might eventually need a skin graft if there's necrosis. Then DIC, which you might now use your platelets transfusion and your FFP. Then the last modality is going to be your rehabilitation, physiotherapy, and counseling. So for rehabilitation, in these are index patients. You could have scarring, amputation. You could even have, so the patient will benefit from drug rehabilitation, as we know that he's a farmer. He'll benefit from drug rehabilitation if he has amputation. From scarring, he'll benefit from physiotherapy. Another part that is important here would involve patient education. So you want to tell him about snake bites, where he shouldn't go to, how he should run his farm, about what to do when he has a snake bite the next time. Then you also want to educate him, counsel him about wearing protective boots, gloves at work, having flashlights and proper lighting at his farm, avoid stepping on snakes, and avoid handling or startling or threatening a snake. So the last question was to mention the antivenom you will use. So that's Equitab plus ICP, which is a trivalent antivenom for spitting vipers, carpet vipers, puff adders. These are the three of Sub-Saharan Africa's most significant snake species. The other ones you can use it would involve your Equitab G, which is a monovalent antivenom raised against Nigerian Echis ocellatus. So at this point, I'd like to give some appreciation to people like Dr. Okopi, Dr. Ibifiri Hart, and Dr. Ali, who have some excellent presentations on snake bites, of which that was the framework of my presentation today. At this point, I'll be taking questions, comments, and suggestions. Thank you.
Thank you very much. Thank you. It's a very good one. We really appreciate, and you've highlighted so many issues that were raised from the question. Thank you. It's the time to entertain some comments, contributions, clarifications, either in a form of chat box or somebody can raise his electronic hand.
Oh my goodness.
Okay, so far, nothing from the chat box, and there is no any electronic hand up.
That's why I had something in the chat box.
Okay, ma. Sorry. Okay,
Oh, okay. Oh, sorry.
Dr.
Apologies.
Okopi said, excellent presentation, dear sister. Sorry, I don't know. Please, did you come across did you mention hydrophidae as a part of the group species?
Yes, Chief. I think so, yes.
Hydrophidae?
The snake, the sea snakes. Yes,
Okay.
Chief.
Okay. So we expect it to be part of this. Okay, yeah, see them there. Thank you. And again, sorry, I was a bit carried away. Do we have a role of benzodiazepines for the management of this patient?
Yes, you could. I didn't mention it, but thank you, Chief, for highlighting that. I talked about anxiolytics, but I was not specific. So you can give anxiolytics, but it depends on the kind of snake bite the patient has. If it's a snake bite that the patient has a neurotoxin and it has already caused confusion and other neurological signs, you might want to stay away from benzodiazepines that might further alter the mental state. But it has a role to play, especially in anxious patients, but low dose, especially in those that don't have neurological symptoms. Yes, sir.
Okay, thank you. Dr. Mamodu said, thank you for the presentation. What are the classification of venomous snakes? An example of each class common in Nigeria.
Okay. All right.
Venomous snakes and the example of each class. It's like you highlighted something of that.
Yes, so I'll just go to the slide here.
Okay.
Sorry. Or does he want the one specifically from?
I think we can use that West Africa. I don't know whether.
Sorry, Chief, I didn't get what you just said.
The question said, thank you very much for the presentation. What are the classes of venomous snakes? An example of each class common in Nigeria. The example should be, if possible, from species of snake in Nigeria from each class.
So I think it was what I mentioned here. I could be wrong, but please. I thought this was the classes, but I could be wrong. So please, I could take help from my teachers or senior colleagues if there are other contributions.
Maybe Dr. Mamodu will share
Yeah.
light for that. But let's read one of the questions he said. Maybe after then we can come back
All
to
right,
this.
that's fine. All right, thank
He
you.
said, he also said, please, what is the role of okay. One of the is there any role of antibiotic in the management of this patient?
Okay.
Hello?
Yes. Okay, let me answer that question. For the modalities of management, I did not think there was a role for antibiotics here because there was no evidence yet of infection. If my full blood count and I could see clinical signs of infection from the site of the bite, yes, I'll give antibiotic, but not from the snake bite, because the snake bite is going to be a snake bite with superimposed infection. So I will not add it as a modality of management unless there is an evidence of sepsis in the patient before I add antibiotics. Thank you. That will be my answer.
Thank you very much. Thank you. Dr. Mamodu said, again, is this bite a myotoxic or hematotoxic?
Dr. Yaya?
Yes, sir.
Please, before you move on that, permit me to say something briefly.
Go ahead, sir. Thank you. Thank you for coming, sir.
Thank you for the presenter and everybody that responded. Now, on the management of anti-snake bite venoms, we must first of all know whether it is venomous or non-venomous, either from the history or clinical findings. But more importantly, we must be handy. We must be readily handy with the 6 A's of anti-snake or snake management. What do I mean by that? We have 6 A acronyms. Though all of them may not be used per unit point in time, but we should still be handy with them. Then we now look forward inwardly whether they need them to be used or not. The 6th one, antibiotics, is one of them. We have antiolytic, analgesic, antibiotic, anti-snake venom, anti-tetanus, and the 6th one, I think anti-inflammatory. Yes. So now on the antibiotics, we can do 2 things. One, most of the patients that present to hospital, some of them have been to traditional setting rather, where they have cut them with a blade and some other thing, they rub something there. So we can actually use antibiotics either prophylactically or therapeutically. Prophylactically, there are any signs that some of these things have been done. They've cut the wound, they've rubbed something funny. Sometimes they rub some funny things that we cannot. So we can use antibiotic prophylactically. However, when we do our full blood count, just like the presenter said, and there are evidence of infections, or even clinically, the patient is running fever, we can now go ahead. Then the other is, we can look whether they actually need it or not. The anti-snake venom, we've said that, anti-tetanus, antibiotics, analgesic, anti-holistic, some of them are highly apprehensive, most especially the females. Then anti-inflammatory, like chymotrypsins, most especially if it is local envenomations. So we can actually consider that. Now, because the time is far spent, permit me to say this. Just like, I don't know, there should be classifications with regards to whether it's no venomation, mild, moderate, and severe, with regards to the clinical findings, the size of the swelling and the likes. And sometimes they may even differentiate there among the species. And that will also guide us on what we use. The vials, 0 to 5, 5 to 10, and greater than 10. But up to a maximum of 25, just like the presenter said. Now, why is it 25? It is said that no matter how big the snake is, per unit venoms or per venoms, it cannot, that 25 vials is enough to mop up all the load of the venoms that may be released. So after 25 hours, and the patient is still not responding, then we have to look inward whether the anti-snake is what's it called, denature or not, because most of the time the cold chain is breached, and this need to be looked into. Why they arrive at the number of hours they use, the averagely 5, 10, and 15, mild, moderate, and severe respectively, is because the venom quantity that this snake release into individual, those vials are able to cater for them. But the exceptions are these two group of anti-snake venom, the ecitap and pactures. They are very potent. In fact, sometimes you use 1 or 2 and everything is clear. You may not need to use that high as 10. It rarely happened, at least with the little experience we have in my center. It rarely happens, except something is long. And if you look at ecitap and pactures, the way they made it, the glass container is like on all others anti-snake venom. Some they even draw the snake there to scare people, but they are not working. So that is just the major contributions. But more importantly, the type of the venoms we are the anti-snake stuff we are using, we must be sure of the potency. Thank you and God bless. Thank to the presenter and everybody.
Thank you, sir, for this wonderful addition. Thank you. Really appreciate, sir. I think let me just quickly read out the chat box because time is not on our side. Dr. Ekele Robert said, thank you very much for the presentation. I think it was mentioned once that we shouldn't give more than 50 vials of antivenom, okay, which sir have taken care of. Then said, thank you very much for the presentation. I think it is necessary to know the most common species of snakes in the area where we practice. In the south, it is the forest viper. It is okay to mention serum urea creatinine since the patient is developing AKI. So he wants us to include that we should know the species in each local environment we practice, and serial electrourea and creatinine in this index patient since the patient is developing what appears to be like acute kidney injury should be included. I think those are the things I can see from the chat box. Thank you.
Dr. Dahatu's hand has been up for some time now.
Okay, ma, I'm not seeing ma. Dr. Dahatu, go ahead, please.
Okay, thank you, Dr. Hapo, for the opportunity. Thank you, ma. Thank you for the presentation. So I think he clarified, but antibiotic is always indicated. It's one of the bites that we must give antibiotics. The full blocker might not help us in the setting of snake bite, because if there is envenomation, there may be, because inflammatory process is ongoing, so you may see the full blocker rising up. So we may not rely on it, but once there is snake bite, some of the animal bite like the cat bite, dog bite, antibiotics are almost always indicated. And in fact, we have to include antibiotic that will cover for anaerobes. Apart from the broad spectrum antibiotic that will cover both gram-positive and gram-negative, we must also cover for anaerobes because of the possibility of tetanus and other anaerobic organisms. So it's important to give antibiotic. Thank you.
Thank you, Dr. Dahatu, for this good addition. Thank you for the contribution. Our chief, sir, Chief Saremi, please, our chief's hand has been off. I just see now. Chief, sir, go ahead, sir.
Thank you, Dr. Aya. Good morning, everyone. I've actually been missing in action for a long time. God will help us. So I just wanted to point out two things. Number one is that the 4 species of snake, that question of 4 species of snake that could cause this. There was one particular species that I expected to be there that I did not see, which is the Naja necropolis. It has to be part of that 4. So Echis ocellatum what's the other one? The Bitis areatans and the Naja Nicolis. Those three must be part of the 4 that you mentioned. It's a must. If the 3 of them are not part of it, then as far as Nigeria is concerned, if you look at that, your trivalent anti-snake venom we were talking about, there are the 3 that are used in that trivalent anti-venom. Okay, so that's one. The other thing I wanted to mention was the diagnosis. I want us to be, should I say, open-minded. In West Africa, I'm assuming is this West Africa or national?
National,
That is
sir.
national.
Okay, so I don't know so much about national, but if it's West Africa, it's a discussion. Okay, so you can discuss. For example, you make your diagnosis as snake bite with envenomation. Maybe you can even say systemic envenomation, because there's already renal impairment involved. So it's not just the local place that is affected. It might also be okay to say something like, with the likelihood of acute kidney injury, considering the worsening renal function. You have not said there's AKI, but you're thinking about it. So it's okay to mention to them that you're thinking of that, because all the information has been given to you. Okay, so there's nothing wrong with that. All right. So I think those are just the things I wanted to mention. Thank you so much for all the contributions.
Thank you, sir, for coming in to contribute, sir. We really appreciate it. Thank you.
Thank you,
I
sir.
think it's high time that we hand over to our chief, Chief Christabel.
Thank you, Dr. Yahaya. Dr. Precious, thank you. Thank you. It was quite a lucid presentation. Thank you so much. Doctor, I want to appreciate everyone that contributed in both presentation